So we're going to talk about acute respiratory failure, sometimes referred to as ARF, and I really think that you need to get a good understanding of respiratory failure so that you can understand ARDS, which is acute respiratory distress syndrome. In order to understand that, you kind of got to have a good grasp on respiratory failure in general. So please listen up. This will be a voiceover recording, and here we go. So what is ARF? It is not a disease, but a symptom that reflects lung function. It's a result of one or more disorders involving the lungs, or other body systems. So it could be something as, the patient becomes extremely acidotic and can have some respiratory difficulties. The cardiac system, such as an MI, they can go into respiratory failure. The neuromuscular system, central nervous system, chest wall alterations. We just talked about attention pneumo, which can lead to respiratory failure. Also, cardiac tamponade. So there's so many things that that can involve respiratory failure, that can cause respiratory failure. ARF Overview, acute respiratory failure overview. It occurs when oxygenation, ventilation, or both are inadequate. So oxygenation is just, the exchange of oxygen and carbon dioxide, and ventilation is just the process by which air moves in and out of the lungs. One or both are inadequate. And like I said, it can be both. You've got your insufficient O2 transfer to the blood, which can cause hypoxemia, decreased PaO2 and SaO2. And what is PaO2? PaO2 is your partial pressure oxygen. It is part of your blood gases, and often you've probably been overlooking that one because you hadn't really had to concentrate on that one in your other studies. But we will be looking at that one from here on out, and you probably will from here on out. So your partial pressure oxygen is just the body's ability to pick up O2 from the lungs. Basically, that's what it is. Then your SaO2 is just your percent of hemoglobin bound to your oxygen compared to how much oxygen hemoglobin can hold. That's your SAT, right? Your SAT percent, your SaO2. Inadequate carbon dioxide removal. So you've got hypercapnia, or increased PaCO2. You've got your increased carbon dioxide. So those things, inadequate carbon dioxide removal, and also you've got your, how do you, assess all this? You usually can look at your blood gases. Like I said, you'll now be paying attention to that PaO2 and all the numbers, and your pulse oximetry. This on the right is just your picture of your blood gas exchange. You've got your deoxygenated blood that comes from the pulmonary artery, and then goes into the pulmonary vasculature, the capillaries, and you've got an exchange of carbon dioxide and oxygen in your alveoli. Alveolus is one, alveoli is many, and we have many alveoli in our lungs. If you took all the surface area from our alveoli and you laid it out flat, it would cover a tennis court. So we have lots and lots of oxygen exchange ability. And then once it's exchanged, as you can see, it turns red, it's oxygenated, it goes out through the pulmonary vein, and this is how we give our body the oxygen. We give our cells oxygen, and we get energy, we can function. Let's compare. So we've got an hypoxemic respiratory failure and a hypercapnic respiratory failure. Your hypoxemic is your oxygenation failure. That is where your PaO2 is less than 60, because our normal PaO2 or our normal levels that we have are 80 to 100 millimeters of mercury. Again, your PaO2 is your body's ability to pick up oxygen from the lungs. So, if it's less than 60 millimeters of mercury, when the patient's getting inspired oxygen of greater than or equal to 60%. So what is inspired oxygen? That is oxygen we breathe in, right? So if you've got a 60%, let's say, with 60%, how do we get 60% oxygen? Well, probably a face mask would give us 60%. A mechanical ventilator, we can set the settings to give us 60%. We can, sometimes a BiPAP. So some of these things we can get 60% oxygen. So if you are getting a non-rebreather and you've got a patient that their blood gases came back, they're on a non-rebreather, and their PaO2 was like 50, you've got a problem. You've got oxygenation failure. You've given them oxygen and they are not responding. So our main problem here is inadequate exchange of oxygen between the alveoli and the pulmonary capillaries or the pulmonary vasculature. So that's your hypoxemic failure. Your hypercapnic or your ventilatory failure. So what is ventilation again? The process by which air moves in and out of the lungs. So if we've got ventilatory failure, we're not moving air in and out of the lungs. So think about your tension pneumo, or someone that's just, you've given them 4 milligrams of Dilaudid, they're barely breathing. They're not moving those lungs up and down. What happens sometimes when you're not moving your lungs, or the lungs are not able to move, you're going to have a buildup of carbon dioxide. So usually you'll see PaCO2 of greater than 50 millimeters of mercury, and they'll be acidotic, which their pH will be less than 7.35. So that's your hypercapnic, just basically a buildup of CO2. Insufficient CO2 removal and the body is unable to compensate. This is just another picture to help you, absorb this. Your hypoxemic is your oxygenation failure. Same parameters, PaO2 less than or equal to 60 on greater than 60% of oxygen delivery. Your hypercapnic is your ventilatory failure. Your PaCO2 is greater than 50, and your pH is less than 7.35. So that is, someone that's acidotic. This can be acute or it can be chronic. So keep that in mind. Both of them can be acute or chronic. What are we going to see? Well, we are going to see definitely some mental status changes, because they're not oxygenating those tissues. They're not oxygenating the cells. So we're going to see some mental status changes. We're going to see early, maybe tachycardia, tachypnea. They may be breathing a little faster. Slight diaphoresis. They may be sweating a little. And then maybe some mild hypertension. So the early signs are not, they're not out just right there in your face. But that is why assessment is so important. We tell you, go back and assess your patient. You need to reassess your patient because things change. And then a late sinus cyanosis. If your patient's lips are blue, that's late. That's not good. So another thing, you may see them positioning. You may see them tripod, where they're sitting, leaned over with their arms out, trying to get their chest to expand and get bigger so that they can have some exchange of air. The pursed lip breathing, where they're trying to blow off that CO2. You may see retractions, where they're using accessory muscles and they're kind of struggling. And then you may see paradoxical breathing, where they're, like a flailed chest, where one side is bigger than the other. And that's why when we're assessing, we say the rise and fall of the chest is equal, because that, you want that. That is a good documentation. And then your lung sounds. What are your lungs sound like? They're crackles, rhonchi, are they diminished? So all of these things are your manifestations. What are we going to see out in, what are you going to see clinically? So why does this happen? Why does this happen? Well, we've already talked a little bit about it, but your hypercapnic respiratory failure is often factors that affect lung tissue. So think your viral, your infections, your pneumonia, factors that affect airway. Think about your anaphylaxis or anaphylactic shock, or your your MVA with a crushed windpipe, or anything that could affect the airway. Chest wall abnormalities, again, your stab wound, your broken ribs, your falls, your car wrecks, things like that. Your congenital, you could have congenital abnormalities, neuromuscular abnormalities. Think about your ALS or your MS, things like that. They can cause your neuromuscular abnormalities. And then a decrease in ventilatory drive. What is ventilation? It's a process of moving air in and out. Well, let's say you give someone a big, huge dose of Dilaudid, and they're barely breathing. They're breathing only 8. Well, they're not moving air. They have a decrease in ventilatory drive. They're not moving the air in and out. What's going to happen? They're going to have a buildup of carbon dioxide in their lungs because they're not blowing it off. They're just breathing very shallow. They're not breathing very good. So that's your hypercapnic. And then your hypoxemic failure, I wanted to get this bigger. You've got a VQ mismatch. You could have a shunt diffusion limitation, and even the alveolar hypoventilation. Let's talk more about all that. Alright, so this is your hypoxemic respiratory failure, VQ mismatch. And this is a figure from your book of the ventilation perfusion mismatch. So your VQ, for whatever reason, is ventilation perfusion. The Q is not in. The Q is just used there. So your ventilation perfusion mismatch. So normal. Let's talk about normal. Normally, we have a 1-to-1 ratio. 1 milliliter of air to 1 milliliter of blood. So if you've got a patient, they came in through the ER, they're checking them to see if they have a pulmonary embolus. And, they've got chest pain. They did a troponin, it was negative. They're doing a VQ scan and D-dimer. Your VQ scan comes back and it's normal 1-to-1, or it's a 1-to-1 ventilation perfusion. Well, that's telling you there's not a PE either. So our normal is 1-to-1. Now, I know this is a little busy, it's a little confusing, so I wanna just show you that I drew a line down the middle to show you the left side. We're talking about like mucus and secretions and stuff, and the right side is more about blood. So A is your absolute shunt. You've got secretions that are so full that no oxygen and carbon dioxide can exchange. So you see that little capillary underneath. There's no blood exchange, so it's just staying deoxygenated. Then you've got B, which there is some exchange, but you see those secretions, that mucus plug, it's kind of blocking them. So you don't have the best exchange, but you do have a VQ mismatch. And then you've got the middle, which is normal. Your normal 1-to-1. You've got some flow. You've got a equal amount of oxygenated and deoxygenated blood, so that there can be an exchange. Then D, you've got a clot, which would be an increase in VQ mismatch. Decreased perfusion secondary to emboli. So you're not, you do have some blue and red there, but you have an increase in the VQ mismatch, so it's it's elevated. Then you've got VQ dead space, which again, that would be like a clot secondary to an obstruction in your pulmonary vasculature, so maybe like a pulmonary embolus. So you would have an increase VQ scan. Your VQ scan would be increased. So that's your VQ mismatch, your ventilation perfusion, and that will often be part of your hypoxemic respiratory failure. If your hypoxemia is not corrected, it can lead to hypoxia, which is more at the cellular level. This goes to the cellular level, but your body compensates some, and you're working to get them to prevent them from going into hypoxia, because if hypoxia occurs, or if hypoxemia is severe, the cells shift from aerobic to anaerobic metabolism. That means anaerobic uses more fuel, produces less energy, and the waste product of that anaerobic metabolism is your lactate level. And your lactate will go up, but it's hard to remove. It's hard to remove from the body because it has to be buffered with sodium bicarb. So just remember that if hypoxemia is not corrected, it can lead to your hypoxia. So think about your septic patient. If we don't get those antibiotics in them within the hour, and we don't give them some oxygen, and we don't get them some fluids, and maybe even a vasopressor or something, then we're getting down to the cellular level. We're going to switch from aerobic metabolism to anaerobic. Our lactate's going to build up, and this can lead to cell death, which can lead to MODS. If our cells are dying off, then we're headed towards MODS. So we're doing all this try to prevent further damage to our body. So your VQ mismatch, your shunt, your absolute shunt, and another example of we talked about the shunt, so no exchange is going on. And then your diffusion limitation is just, it occurs when gas exchange across the alveolar capillary membrane is compromised by a process that destroys the alveolar membrane or affects the blood flow through the pulmonary capillaries. This, like some fibrotic lungs, or this can often happen sometimes with ARDS. So, diffusion limitation, and then your alveolar hypoventilation, and it's just a decrease in ventilation, which we're back to ventilatory failure. And you get an increase in carbon dioxide or acid that builds up. And think about your asthma, your restrictive lung disease, and this is, mainly a mechanism of hypercapnic. That's why I say they can have both. So that is why, the why. What do we do? What do we need to do? Well, of course, we're going to do ABGs. We're going to do a chest x-ray, pulse oximetry, frequent vital signs, CBC, 12-lead EKG. We need to do those blood cultures. Remember, we need to do that within the hour. We need a VQ scan. And if they're on a ventilation, we need that end-tidal CO2. We want to see if the vent settings are set at the right, if they're set correctly so that they are not holding on to CO2. So that's the end-tidal CO2 monitor. And then I just threw this in because it's been a while since you went over this, and we just talked about our O2 delivery, and we want it, 60%. If you're not seeing any result with your face, with your nasal cannula or your oximeter, then we need to go up. So our O2, our FiO2 is 21% on room air. So you and I are breathing 21% of Fi, fraction of inspired oxygen. So we are breathing about 21%. So then you can add a couple of percent, 2-3%, depending on what book you're reading, as far as, when you raise your liters of oxygen. Remember that you don't want to turn up your face mask, your simple mask, or your nasal cannula above 6. Usually you want to try something different. If you're needing to turn it up to 6 and you're not seeing a result, then we need to switch to something else. Non-rebreather, partial non-rebreather, maybe a BiPAP, CPAP, something like that. So then your partial non-rebreather, if you remember, we talked about how to make sure that if you don't know how, you need to make sure you know how to make sure this is properly applied to the patient. And you need to make sure your reservoir bag is inflated. So the way to do that is to turn your oxygen on, hook up your oxygen tubing, and then put your finger over the valve so that the bag will inflate, and then put it on your patient, because you want it to be inflated so that they can get a good amount of oxygen. And you just it delivers the highest oxygen possible without intubation, and it's short term, but this non-rebreather has the valves to allow the CO2 to be blown off. So that's just a quick review on the different delivery methods. There is an oxymizer that would go in between the nasal cannula and simple mask, and it just gives you a little bit more oxygen than the nasal cannula. The CPAP is another. It's a non-invasive positive pressure therapy. So it's just continuous positive pressure airway, and it is pressure delivered through, so when you're breathing, it's just giving you some pressure so that you can have a better gas exchange. It's used to prevent and treat sleep apnea, because some people have the obstructive type, and they need that high flow, to help them prevent their, I might be saying this wrong, but I think it's the epiglottis that falls down, so this high flow will help prevent that. And then this is non-invasive, so just a mask or nasal pillows or something like that. Then your BiPAP, and BiPAP is a brand name. It's you may hear it called something else. You may hear it called CPAP with bi-level or different things like that. But it's positive pressure airway. It's non-invasive, and it delivers oxygen 2 levels of pressure. Higher with inspiratory, so they get a little bit more pressure when they inhale, and then a little bit lower when they exhale, so they don't have to push against that wall of air for better to keep the alveoli open and aid in gas exchange. So a better exchange of gases. It's non-invasive. You do want to make sure that it's fitting correctly and that you're getting the optimal oxygenation. And they have to be able to they have to be able to breathe spontaneous and cooperate with this. Otherwise, they're going to need to be intubated. And we will talk more about intubation in another lecture. But this is all I have for you on this. So just make sure you understand the differences between your your hypoxemia and your hypercapnia, and that you have a good understanding. And I hope you have a good rest of the day, and I will see you soon.